afternoon. On behalf of SDPI, I welcome you to this webinar on universal health coverage and social health insurance in Pakistan. Speakers are requested to keep their microphones off when they are not speaking to ensure good audio quality for everyone. You're also encouraged to switch on your cameras, especially when you are speaking, if your network allows to do that without any disruptions. We also invite questions from our audience and colleagues at the end or as the session goes. Please feel free to write them in the Q&A box on the right side. Speakers are requested to keep the chat box open in the window. You can also indicate that you want to speak by clicking the raise hand tab on the right side of the chat window. The session will also be telecasted live on SDPI's Facebook page. For those watching us on Facebook Live, please write your questions in the chat there. They will be conveyed to the speakers through our team. The seminar will be recorded and the video will be posted online. You are welcome to revisit the discussion later and feel free to share it with your network. Views expressed during all webinars are the views of the respected speakers and do not represent the policy of the organization. Today's session is moderated by Dr. Razia Safdar, Senior Advisor, Center for Health Policy and Innovation, SDPI. And now I hand over the session to her so we may begin the proceedings. Thank you.
Thank you, Aisha, for your introduction. And let me start today's webinar is basically, as you all know, is on the universal health coverage. And it's the first of series of series of webinars on different components of universal health coverage. And on behalf of Center for Health Policy and Innovation at SDPI, I thank you all expert panelists for joining us. And actually, Pakistan is the first country to develop the costed essential packages of health, universal health coverage for all levels of health service delivery, like primary healthcare, secondary healthcare, and tertiary healthcare, and in community also. So it was Ministry of Health's long consultative process with experts, policy, community, and implementers at provincial level. These packages are based on disease control priority 3 and burden of disease studies, and which has helped in prioritization of the interventions which can be done in Pakistan. So, and now as it is in the implementation phase, it is in line with the National Health Vision of Pakistan, which is a policy document. And Pakistan is also a signatory of SDG 2030 agenda, and related SDGs with this are 3.8.1 and 3.8.2. So so this was the I just wanted to introduce this universal health coverage, the relevance of this, because still we are facing with the COVID-19 health issues. So with the formal, I think this with the for the formal inauguration, I would like to hand over to Dr. Abid Suleri, Executive Director SDPI, for his remarks. Dr. Abid is heading SDPI since 2007 and is a member of Prime Minister's Economic Advisory Council. And he is national convener of the National Committee on Agriculture Transformation Plan. He is member of Climate Change Council, member of Research Advisory Committee, National Institute of Public Policy, Lahore, and many other committees. And he has a special insight on socio-economic, food security, and food safety issues in the Pakistan. And health determining, external determining factors is like environment, food security, food safety, and others, and robustness of the health delivery systems. So over to you, Dr. Abid Suleri, for your insights and vision of the SDPI keeping health in focus. Thank you very much.
Thank you very much, Dr. Razia Safdar. Good afternoon, good morning, good evening, ladies and gentlemen, depending from where you have joined us in this virtual space to discuss the prospects of universal health coverage in Pakistan, some of the challenges and opportunities here, and how we can turn it better in the year 2022. If I look back and try to see Pakistan's achievements during last 2 years amidst COVID, I can really feel proud of our public health system. The way it got evolved, I remember that when COVID-19 was declared as a pandemic, and when we had to send first few specimens of the suspected patients to China to trace whether those were infected by COVID till today. So I think government's preparedness, that is quite visible. It is also quite ensuring that in Pakistan we were able to get access to vaccination. So those Pakistanis who wanted to get vaccinated for COVID-19, at least the supply was not a constraint. So in and even now this vaccination in schools for the children above 12 years of age without any discrimination among private or those public schools or the madrasas, etc. So I think these are some of the good news perhaps on which we can conclude the year 2021. But I think one of the important things, as Dr. Razia mentioned, is about this initiation of the program for universal health coverage. This Sehat cards, which are being distributed in different provinces, is one of them. But now the new proposal that CNICs, those would also be considered as Sehat card. I think that's even one step further, that anyone who is holder of CNIC or who is holder of POC can actually go and avail health services. But as Dr. Razia mentioned, that when we say universal health protection, perhaps we are only confining ourselves more towards preventive or curative intervention, or sometimes health promotive intervention. But what is important is also to take care of allied factors which somehow determine our health, which determine our body immunity, and which determine the chances of us getting exposed and getting infected to different pathogens or not. And I'm referring to environment, I'm referring to food security, I'm referring to clean drinking water, I'm referring to sanitation facilities, and I'm referring to education, because education actually then shapes our attitudes, education shapes our behaviors, and many a time it's our attitudes and behaviors that can define whether the chances of us getting exposed and getting infected to pathogens or not. So this universal health protection in a country of 220 million inhabitants, it's really a gigantic task, and now one has to see that where are the windows of opportunities where public sector, private sector, and international development partners, they can actually combine their efforts, they can collaborate, they can support each other, because when we talk of universal health coverage, it's not only the public sector that can take care of it. I think it's our collective responsibility, and in order to deliver this collective responsibility, the opinion of experts like Dr. Sameen, Dr. Arshad, and Dr. Khalid, and others who are present on this panel, these are extremely important. We'll not only carefully listen to your recommendations, but also compile and collate them for the decision makers, and we'll try to float them at relevant decision-making forums so that those can be implemented. Thank you very much for joining, and thank you, Team SDPI, for organizing this very important webinar.
Thank you, Dr. Abid, for your insights and your remarks. Now I would like to invite Dr. Sameen Siddiqui, who is our first panelist, and he's a professor of Department of Community Health Sciences, Agha University, Karachi. And earlier he has a long experience of working with the World Health Organization for almost 16 years. He was where he served as a director and health system development, covering the Eastern Mediterranean region. He spearheaded the work on universal health coverage. He has also served as WHO's rep in Lebanon and Iran. And Dr. Siddiqui has a fellowship in internal medicine, master's degree and fellowship in public health from UK, and doctoral degree from the Heidelberg, Germany. He has worked for over 2 decades advising lower and middle income countries on strengthening health systems. He has special interest in health systems governance, private health sector, public-private partnership, and quality and safety of care. Dr. Siddiqui, welcome, Dr. Siddiqui. He was involved in the whole process of adoption of the universal health coverage in Pakistan and in other countries as well. So it's I think this is a good opportunity to ask you what is the universal health coverage basically, when we are talking, what are the main components of it, and and what are the practices in other countries, and what is expected impact on health of the people in Pakistan after the implementation. Over to you, Dr. Sameen.
Thank you, Dr. Razia. Thank you, Dr. Suleri, for asking me to be part of this panel. Assalamu alaikum and good morning, good afternoon to all of you. So let me pick up from where Dr. Suleri sort of brought up a very important point. And let me start by saying that, health is a function of both interventions within the health sector, but also a lot of interventions outside the health sector, as we all know. So when he talked about water, sanitation, food security, and all those, these are health determinants. Because I want to scope I want to sort of frame this discussion, at the moment there's a lot of debate on whether what falls within UHC and what doesn't. So for the moment, I would like to say that universal health coverage, and that's what the subject is, will be looking at if you're looking at 4 key aspects that we're talking of UHC. First is covering all. That's why it's called universal, so coverage for everyone. Second, coverage of all with an essential package of health services that is available to everybody in the country, rich or poor, urban or rural, young and old, and whatever. The third aspect of universal health coverage is that when these services are provided, they are of good quality. And quality is essential, and it is integral to UHC. And sometimes we may have access to services, but not the quality. And the fourth thing, which is essential to UHC, is that while we provide services, when people receive these services, they are financially protected and are not exposed to any form of financial hardship, ruin, or anything. And we know from our experiences around us that many a times people suffer from financial hardship when they are seeking health services, especially for serious conditions. And actually, we know from evidence that it can drive households into poverty as a result of catastrophic expenditure. So when everybody is being covered with an essential package, which are of quality, and the population is financially protected, we are moving towards universal coverage. Now, this is easier said than done because that's what countries across the world and LMICs are struggling with. Many have done it, but many countries are moving in that particular direction. Around all of this, what I've just said is the whole area of governance, because to be able to do this, you need to be able to have good governance mechanisms, both within the government, within the ministry, and of course, with the governance around insurance organizations, if they are a significant part of that. So that's the whole part. Now, let me just pick up on 2 aspects of this. One is how to come up and decide what services, and the second is how do we fund those services. Now, you cannot just choose those services just the way we did it, or just the way anybody wants to do it. It should be based on some solid evidence. And that's why I think we need to acknowledge the good work that Pakistan has done over the last 2 years because Pakistan has developed an essential package of health services, which I have to say today has the concurrence of all the 7 provincial government. I mean, the 4 provinces, the federal government, and the HAK and GB. And I was fortunate enough, along with the ministry, the DG, to present it to these ministers where it was formally endorsed. So one work which was done over 2 years has been done, and we have a fairly well developed package, which I would like to acknowledge the health policy unit in the Ministry of Health, which has done some excellent work, in developing that package. So that kind of work has been done. We have a package, it's been provincialized, but it is not getting implemented. But we know what those essential interventions are. The important point is that these interventions are targeting the major health problems, are pretty much within the budgetary impact. They cost about $14 per capita. So they've been really worked out after a lot of consensus, participation, analysis. And I can tell you, not we, but many people in the world are promoting the way Pakistan has done that work. So when good work is done in Pakistan, I think we should acknowledge that. And I think that is a good piece of work. When I go to international forums, this piece of work really gets appreciated by many international forums. So that's the package which we already have. I can give you details of those packages, but that's not, I don't think that I need to get into that. The second part, which I think I'd like to touch on before I close and pass it on to the next panelist, is the financing of this package. So we have the package, but from where do we get the money to implement that package? And that's a challenge, and that sometimes is called, do we have the fiscal space in our system, in our government to be, and given the current economy and the macroeconomic situation, Pakistan is challenged with that. So how much does Pakistan spend on health today, if you ask me? And without taking what has happened in terms of the current devaluation and the loss of the value of Pakistani rupee in recent times, if I'm being optimistic, we are spending somewhere around $45 to $50 per person per year on health, which is really, really underfunded. Now, don't think this is government expenditure. This is the total expenditure that we are doing, of which the government spends about 1/3, and the rest is happening in the private sector as what we call out-of-pocket spending pretty much, which is exactly what we don't want. And we want people to spend less and less out-of-pocket and much more through prepayment systems. One of the prepayment initiatives is what is being called the Social Health Insurance Program, which we call the SSP, or the Sehat Sahulat program, which is trying to bring in the element of health protection and financial protection. And we'd like to hear from our colleagues as to how that is moving forward. But we would very much like to see, to sum up in my first round, we would like to see that we have the essential package, which gets implemented at the district level, which is well funded, which is of good quality, and our information systems and governance mechanisms are robust enough to be able to implement that particular package, so that at the end of the day, it is not about DHC, it is about bringing about an improvement in health outcomes of our people, which they so richly deserve. So I'm going to stop here now. I can keep saying, because this is an area which I work with a lot, but I think in my next round, if time permits, I'll say a few more things. Back to you, Dr. Razia, for more comments.
Thank you, Dr. Sameen, for your comment. And I think well highlighted about the financial aspect of this for implementation of universal health coverage packages. And our next panelist is related to Mr. Mohammad Arshad, who is the CEO of Sehat Sahulat program in Pakistan. And he has a 30 years experience of working in insurance, health insurance, and health insurance sector, finance sector. He was qualified from IBA Karachi, and so welcome, Arshad Saab. And I would like to ask you, so far, the Sehat Sahulat program is now in, I think, 6th year of its inception from the start. And I think now we know that it has impacted on the targeted population, health of the targeted population. So can you briefly tell us about the Sehat Sahulat program's main impacts on this on the health of the targeted population so far. And how can that, and as you said that my second question is how can we integrate, or how can we get benefit from the Sahulat program while implementing the universal health coverage? Thank you.
Thank you, Dr. Razia, Safdar, and Dr. Suleri, inviting me to this event to share some of this from our side, how Sahulat program is contributing within the health. As Dr. Razia very well mentioned, there's now SSP or Sehat card or Sahulat program is 6-year-old child. Now is growing up in almost all the dimensions. जब 2015 के आखिर में और 2016 के इब्तदाई दिनों में somewhat designed and conceived by both the KP provincial government and the federal government and Islamabad. The intention in one line was to protect Pakistan's below average and below poverty line families from catastrophic healthcare expenditure. इसलिए कि न सिर्फ पाकिस्तान में बल्कि दुनिया भर में होने वाले जितने भी poverty survey हैं, both have proved that 46% of families fall below the poverty line is due to catastrophic expenditures. This was the intention when this program was conceived. This program was started with a pilot project in 4 districts of the KP and 23 districts of the federal government purview in all the provinces almost, including Sindh, Balochistan, AJK, GB, KP. So this is how this is what it started. And the intention जो लोगों के out of pocket expenses हैं उसमें कमी की जाए at least catastrophic healthcare expenditure को लेके. As Sameen and other my professional colleagues have already defined and they will further elaborate के जो हमारे WHO की definition के हवाले से या जो international recognized definitions के हवाले से universal health coverage का domain या spectrum क्या है. But in the simple language for the general audience, there are 3 key segments of the healthcare sector. One is catastrophic healthcare expenditure related hospitalization services, जहां इस बात के हर तरीके से इम्कानात होते हैं कि the person or the family suffer or can die both physically and financially. And the other one is more is with the OPD related services, जहां नज़ला, जुकाम, खांसी, जहाँ छोटे से अखराजात में हर फैमिली अपनी पॉकेट के लिहाज से अपनी लोकेलिटी के हिसाब से सर्विसेज ले लेती है और इन बिटवीन इनके जो है वो बेसिकली क्रोनिक मेडिकेशन रिलेटेड सर्विसेज हैं. These are the 3 की आप कह लीजिए क्यूरेटिव डोमेन के 3 एस्पेक्ट्स हैं. इसमें पहले डोमेन से हमने आगाज किया है कि पहले मरहले पे जब भी मैं कहीं जाता हूं तो लोग मुझसे यही पूछते हैं कि why it was started from the inpatient. The reason was we wish to save the lives first. पहले हमने जिंदगियां बचानी थी, इसलिए हम हेल्थ कार्ड में इन पेशेंट या हॉस्पिटलाइजेशन सर्विसेज को लेकर आए जहां लोगों को जिस्मानी और माली दोनों तरफ मुश्किलात का सामना था. And we tried to cover almost every possible secondary coverage or tertiary coverage related issues under the umbrella of Sahulat card or Sehat card, with exception of transplants and implants. अब ट्रांसप्लांट भी ग्रेजुअली इसके अंदर शामिल किए जा रहे हैं. किडनी डाल दिया गया है और लिवर जो है वो केपी शुरू कर रहा है, लाइकली कि हम उसको फॉलो करेंगे. तो दिस इज हाउ कि ऑलमोस्ट इसको यूनिवर्सल कवरेज जो है वो आप कह लीजिए इन टर्म्स ऑफ हॉस्पिटलाइजेशन बेनिफिट्स उसकी तरफ हम जा रहे हैं. प्राइमरी हेल्थ केयर को ले लीजिए, ओपीडी के अंदर हम जो है एक पायलट प्रोजेक्ट कर रहे हैं विद इन द सिलेक्टेड यूनियन काउंसिल्स ऑफ इस्लामाबाद with the collaboration with the WHO, and hopefully by next October उसके रिजल्ट्स हमारे सामने आ जाएंगे. अभी हमने कैपिटेशन मॉडल लाइक ईरान एंड सम अदर कंट्रीज उसका एक थोड़ा सा हाइब्रिड मॉडल बनाया है जहां जीपीज अपॉइंट करके और फैमिलीज अटैच कर दी गई हैं. तो होपफुली विल सी द एविडेंस और उसका रिजल्ट क्या आता है और उसकी रोशनी में हम फैसला करेंगे कि हाउ we should go for inclusion of the OPD coverage or primary health care in future. या इसके लिए हमें कोई और मॉडल अडॉप्ट करना चाहिए गवर्नमेंट ऑफ पाकिस्तान को to offer these services to the below the poverty sectors and to the rest of the sectors of the society. Third one, but I would like to concentrate more what Dr. Sameen very well said कि जी इससे भी एक पिछला मरहला है. Dr. Suleri also identified कि असल में तो प्राइमरी हेल्थ केयर तक भी नौबत नहीं आनी चाहिए. We should focus our efforts and our resources and our time towards the preventive side. तो वो काम करने की जरूरत है कि प्रिवेंशन पे हम कितना अच्छा काम कर सकते हैं. And I strongly believe in the famous English जो proverb है कि one stitch in time saves 9. Every single public health scientist भी यही कहते हैं कि every single dollar spent in the prevention we save in the primary, and every single dollar we spend in the primary we save $10 in the secondary care or the tertiary care. हमारी भी ख्वाहिश और कोशिश यही है कि किसी तरीके से हम नीचे ज़्यादा से ज़्यादा अगले मराहिल में इन्वेस्ट करें अपने एफर्ट्स को, अपने रिसोर्सेज को, अपने टाइम को, ताकि हम सेकेंडरी केयर और टर्शियरी केयर पर लोड कम कर सकें. दूसरी बात, आज when we are talking this subject, we are passing through a sort of historical movement कि पहले हमने ये प्रोग्राम बिलो पॉवर्टी से शुरू किया था जहां 32.5 PMT स्कोर के नीचे जो NACR सर्वे के नीचे फैमिलीज थी उनको हमने इसमें कवर किया था. उसके बाद वल्नरेबल फैमिलीज लाइक ट्रांसजेंडर्स, लाइक PWDs, उनको हमने इसमें शामिल किया. उसके बाद हमने तजर्बा किया ग्रेजुअली, पहले थरपारकर में, फिर फाटा में, उसके बाद AJK में और उसके बाद KP के अंदर कि हमने यूनिवर्सल हेल्थ इंश्योरेंस कवरेज का आगाज किया, जहां हमने सारे के सारे खानदानों को इसमें शामिल कर लिया irrespective of their income levels or any other discriminatory aspect. इसको हम 100% परमानेंट रेजिडेंट फैमिलीज को दे दिया. और आने वाले अगले 3 दिन बाद प्राइम मिनिस्टर साहब जो 31 दिसंबर को इंशाल्लाह फ्राइडे को लॉन्च कर रहे हैं यूनिवर्सल हेल्थ इंश्योरेंस कवरेज फॉर ऑल द फैमिलीज ऑफ द पंजाब, which means 12 करोड़ इंसानों को. पंजाब if you see from the population size तो दुनिया की 10वीं बड़ी कौम है. तो पूरे पंजाब को, पूरे इस्लामाबाद को, पूरे गिलगित बल्तिस्तान को इसमें शामिल करने जा रहे हैं as far as the universal health insurance for the inpatient services, वो इसमें शामिल होने जा रही है. और बलोचिस्तान गवर्नमेंट is also considering to join the train in next couple of months as we had a conversation with them. सिंध गवर्नमेंट के साथ भी हमारी डिस्कशन हुई है. दे आर आल्सो वेरी पॉजिटिव और ज़रा इम्कानात हैं कि 2022 के किसी हिस्से में वो भी इस ट्रेन को ज्वाइन कर लेंगे. एंड इफ इट गोज लाइक दिस तो वी विल बी द फर्स्ट नेशन ऑन द प्लेनेट ऑफ 234 मिलियन पॉपुलेशन साइज जो स्टेट फंडेड यूनिवर्सल हेल्थ इंश्योरेंस कवरेज पे जा रहा है फॉर द इनपेशेंट सर्विसेज. So all the people are having their fingers crossed. All the experts in the health insurance world, they are observing us very carefully कि हमारा ये तजर्बा आने वाले वक्त में in terms of the service delivery, in terms of the financial sustainability, or from other aspects कैसा जाता है. And we are very confident कि जी चाहे service delivery के aspect से देखें, we do have the infrastructure for the service delivery, but the problem is same like any other developing countries. हमारे साथ भी मसला यही है कि हमारे जो हेल्थ की फैसिलिटीज हों या जो तालीम की फैसिलिटीज हों, जो भी ढंग की फैसिलिटीज हों, दे आर कंसंट्रेटेड इन द अर्बन एरियाज. लाइक KP, अगर मैं एक पेशावर की बात करूं तो आधा एबटाबाद के बाद बाकी सारा पेशावर KP जो है खाली नजर आता है हमें. सेम लाइक पंजाब, सेंट्रल पंजाब के कुछ बड़े शहर लाहौर को छोड़ के, मुल्तान को छोड़ के is also empty. Same is about you see Sindh after Karachi and after you say Hyderabad and Chauthai Sakha, there is no other reliable facility available. तो इसी तरीके से ये बलोचिस्तान में तो बहुत ही बुरा हाल है. कोयटा I don't consider even half. It's like 0.33. और खुजदार के एक आध फैसिलिटी के बाद पूरा बलोचिस्तान 46.4% of Pakistan is just empty. अब आइए कि इस प्रोग्राम से फर्क क्या पड़ेगा. ये क्या फर्क अब तक पड़ चुका है जिसे डॉक्टर रजिया पूछ रही थी. देखिए इवन फाटा कंट्री लाइक एरिया लाइक फाटा जो कंट्री का सबसे ज्यादा बैकवर्ड एरियाज था, कोई पिछले 2-3 साल में जब से हमने यूनिवर्सल हेल्थ कवरेज वहां दी है, कोई 25 से 30% नई फैसिलिटीज जो है प्राइवेट में इमर्ज हुई हैं. अब जस्ट विश टू गिव एन एग्जांपल ऑफ केपी. उन केपी के अंदर कोई 15 से 20% जो है वो नई फैसिलिटीज اور ایون 12 कैथलेब में पिछले 12 महीने में 14 महीने में वजूद में आई हैं. एंड सेम लाइक इन अदर एरियाज जहाँ हमने यूनिवर्सल कर दी है लाइक एजे के एज पर. और यही चीज़ें हम अगले 5 साल में देखने जा रहे हैं. मेरा ख्याल है कि पंजाब में भी और जीबी के अंदर भी. मतलब I don't feel so proud being a nation, being a health expert कि पिछले कोई 75 सालों के अंदर हम जीबी और एजे के जैसे बड़े इलाकों के अंदर हमारे अभी तक कोई ढंग की रिलायबल कार्डियोलॉजी या कोई ऑन्कोलॉजी की फैसिलिटीज हम डेवलप नहीं कर सके. बट आई एम वेरी कॉन्फिडेंट विद दिस फिनोमिना, विद दिस यूनिवर्सल हेल्थ इंश्योरेंस कवरेज, जब बिजनेस अपॉर्चुनिटीज और बिजनेस केस वहाँ स्ट्रॉन्ग हो रहा है तो पीपल आर वर्किंग. Yesterday, GB Chief Minister was telling me कि कोई 4 के करीब जो है टीचिंग हॉस्पिटल की इन्वेस्टमेंट की प्रपोजल आई हुई है उनके पास. इसी तरह और लोग हैं जो हॉस्पिटल या हेल्थ सेक्टर में इन्वेस्ट करना चाहते हैं. तो वी विल बी सीइंग मोर आई थिंक इन डेज टू कम. आखिरी में 2 गुजारिश करूंगा कि एक सवाल अक्सर किया जाता है कि जी हाउ यू सी कि जनाबे वाला ये प्रोग्राम जो है कितना सस्टेनेबल है इन टर्म्स ऑफ फाइनेंसेस, क्योंकि हमारी जो इकोनॉमी की सिचुएशन है या जो हमारा हेल्थ सेक्टर की जो सिचुएशन है, वल्नरेबिलिटी है, तो उस कॉन्टेक्स्ट में अभी मैं ख्याल है कि डॉक्टर समीन कोट कर रहे थे कोई $45 के करीब मैं ख्याल है कि खर्चा एवरेज पाकिस्तानी कर रहा है, जिसमें से कोई $15 जो है वो एक पब्लिक सेक्टर से हो रहा है या गवर्नमेंट कर रही है. If I accumulate all 4 provincial, 2 regional and 1 federal government's expense or budget for 2021, it almost accumulates to 650 billion rupees per year. 650 अरब रुपए साल के हेल्थ सेक्टर पे पाकिस्तानी हुकूमतें खर्च कर रही हैं. If I see my bill or ticket size for the national health insurance, अगर मैं सारे पाकिस्तान की यूनिवर्सल हेल्थ इंश्योरेंस कर लूं, जिसमें कि 70-80% हम करने जा रहे हैं 1 जनवरी से, अगर सिंध को भी शामिल कर रहे हैं तो 200 अरब के करीब रफली इसका जो है वो बिल एक्सपेक्टेड है. Still 450 billion rupees are available for all primary care, for all chronic, for all vertical programs, for all preventive activities. मैं मौजूदा बजट की बात कर रहा हूँ, उस बजट की बात नहीं कर रहा है, टोटल हेल्थ एक्सपेंडिचर की बात नहीं कर रहा हूँ. तो देयर इज स्कोप कि अगर आप प्रायोरिटाइजेशन करें और चीज़ों को सही चैनलाइज करें तो कोई वजह नहीं है कि न सिर्फ ये प्रोग्राम बल्कि आने वाले वक्त में जो हम प्राइमरी हेल्थ केयर का जो हम एसेंशियल हेल्थ सर्विसेज पैकेज को लेके जो हम पायलट प्रोजेक्ट कर रहे हैं, तो आई होप वहाँ से भी इंशाल्लाह अच्छी खबरें आएंगी. एंड वी वुड लाइक टू इंक्लूड फर्दर दीज थिंग्स. और आखिरी बात मैं जो करूँगा वो पब्लिक हेल्थ के पर्सपेक्टिव में खास तौर पे करूँगा कि आज से पहले होता ये था कि अगर डेरा बुक्टी के अंदर या टंडोवालायार के अंदर या कोटली लोहारा के अंदर कोई डेंगू का, हेपेटाइटिस का, HIV का कोई अगर स्प्रेड होता था तो इस्लामाबाद या सूबाई कैपिटल तक खबरें पहुंचते पहुंचते मीडिया में शोर मचते मचते महीने लग जाते थे. उस वक्त तक सूरत हाल काबू से बाहर हो जाती थी. बट नाउ विद द यूनिवर्सल हेल्थ इंश्योरेंस, with the Sehat Sahulat program database, the real time जो हमारा CMIS है, it shows every single diagnosis, every single admissions. मैं आपको पिछले हफ्ते के दिखा सकता हूँ, रियल टाइम दिखा सकता हूँ, बता सकता हूँ कि डेरा बुक्टी में किस चीज़ ने स्पाइक किया है, HIV ने अगर लाड़काना में स्पाइक किया है तो किस क्वांटिटी में किया है. तो इंस्टेड ऑफ वेटिंग the public health team can make a preemptive actions और उसके बाद उस चीज़ को उसी जगह लिमिटेड करके बहुत ही इफेक्टिव स्ट्रेटजी के साथ, इफेक्टिव एफर्ट के साथ हम कंटेंट भी कर सकते हैं और मैनेज भी कर सकते हैं. तो आई एम वेरी होपफुल कि जो पहला कदम हमने सेहत कार्ड की शक्ल में उठाया है, इट विल बी ए फर्स्ट स्टेप टू अ लॉन्ग जर्नी, बट इट विल बी द डिसाइसिव स्टेप इन टर्म्स ऑफ द हेल्थ रिफॉर्म्स और द हेल्थ सेक्टर रिफॉर्मेशन. थैंक यू वेरी मच.
Thank you, Arshad Saab, for a very comprehensive overview of Sehat Sahulat program and very informative also for example, the last example of your information system, which is quite robust and which can give us the more space to work on that. And now our last panelist, I will introduce Dr. Khalid, who is working at Health Policy Unit at Ministry of National Health Services and Coordination. And he brings with him he has a decade of working experience with the government and other private sectors. He completed his basic MBBS from in 2004, and Dr. Khalid then did his master's in public health with distinction from prestigious University of Warwick, UK in 2007. Since 2006, he has been working in the public health sector. And Dr. Khalid is at Ministry of Health. He was the key person to, and he is a focal point for universal health coverage at Ministry of Health. And also he was thoroughly involved in all the process of development of from the initial consultation to the final consultations, as well as the development of the health packages. He is the brain behind all the the documents and everything which came up on the papers after consultations. So Dr. Khalid, I would like to tell us about something about your process and the main feature of the universal health coverage packages which are made and which will be implemented at the district levels. Thank you very much. Should we share your presentation, or you can share your presentation?
Presentation. I'll talk as such, yeah.
So, should we share? Or?
No, I think I can go without the presentation. That's what I'm saying.
Okay, okay,
yeah.
Fine. Go ahead.
So thanks. Yeah, so thanks, Dr. Razia. Thanks, SDPI and Dr. Suleri for the invitation. This is extremely important session where we are discussing something which is now a central point for reforms in the health sector in Pakistan. And as Dr. Sameen said, that it has an ownership at the federal and provincial level with health sector and related sectors chipping in and showing the ownership. Dr. Sameen has already given details of what universal health coverage is and the other details, so I won't go into those details, but I would just like to make a distinction between universal health insurance and universal health coverage. Basically, universal health coverage, as Dr. Sameen informed, that it basically has 4 dimensions. 3 dimensions. Basically, one is qualitative aspect, the quality of the services. So the first thing is that you need to cover the whole population. Number 2, you need to provide a set of identified essential package of health services to the whole population, and then provide those services without incurring financial hardship on the people. So basically, the services, identified services, are the services which addresses the majority of the burden of disease of the population. Whereas now comparing this with the universal health insurance means that all the population, say in a given province, has been enrolled into the insurance program. The difference comes at the set of services or list of services that are covered by that insurance program. Like Mr. Arshad reflected that at this stage, primarily they are providing the health services that are catastrophic in nature, that primarily requires admission to the hospital, that is the inpatient care. So the outpatient services as of now are not provided through the health insurance program, and obviously it takes time, and they're moving towards that, and they have piloted the OPD services via capitation model in some selected UCs of Islamabad. However, that obviously is the difficult bit of the insurance program, because doing reimbursements for the established medical procedures or operations, or it is relatively easier compared to the services that are being provided through OPDs. Having an account and transparency within the purchasing of those services and provision of those services becomes much more difficult when you compare the inpatient services with the outpatient services. So I'll stop here with the difference between the two, and I will now, because the agenda was quite open, and there's a lot, there are a number of areas where we can have a discussion on the universal health coverage implementation in Pakistan. But as Dr. Sameen rightly said, the most important bit is the financing, that how would we finance this package, and what is the roadmap? How do we proceed forward in terms of financing mechanism, and where to go in coming 10 years, say, for instance. So I'll just try to zoom out and put few, you can say, questions in front of this August gathering to have their reflections on them. So basically, if you look at the total health expenditures that we had in Pakistan in 2017 and 18, as per the last published National Health Accounts report, they were around 1206 billion PKR. That is the amount of money that was being spent on health in 2017 and 18. And the cost of the UHC interventions that we prioritized, or the package we developed, is around 1288 billion PKR. So the 1206 billion PKR, that was the actual expenditure of Pakistanis on health during the 2017 to 18 is a considerable amount. Now, what is the issue? The issue is the service provision is very fragmented. You have federal vis-a-vis provincial health departments. You have state-owned enterprises which have their own systems of provision of health services. You have military healthcare system. You have cantonment board system of healthcare service provision and cantonment boards. You have autonomous bodies like railways and PIA and others, so many of them, who basically are spending a little or more money on the health. So this makes it quite a considerable amount of money that is being spent on health, and obviously the biggest chunk coming from the pockets of the people are spending on it. So the big question is, and the question in my opinion, to the way forward in this regard would be to identify or to mature systems that can effectively pool this money that is being already spent. Obviously, government needs to increase its spending on health. There is no doubt about it. But whatever is being currently spent, if we move towards systems that can effectively pool this money, we can sort of have bigger fiscal space available to bring about the much needed reforms. I think what needs to be done is quite clear. The important bit is the availability of finances for it. So how to pool the money? The question is how to pool the money, how to pool this whole money. Currently we have the general tax-based financing mechanism of the health services, where through direct taxes and indirect taxation on the consumption of different commodities, we have a general tax collection by the government, and then they identify that, okay, fine, we will spend this percent or proportion of the money on the health of the people. So that is one way of pooling the money. But this has been in place for quite some time, and it has somehow not been able to pool effectively. The other is the social health insurance, which is actually the basis of the Sehat Sahulat program at a limited scale, including only the inpatient services. But there are issues when you talk of social health insurance in the context of Pakistan. First question is, should government pay as they are currently paying for the premiums of all the insured population? We have covered all the population in KP and going to cover all the population in Punjab for the inpatient services. All population means it will not only have the poor segment of the society, but it will have people who are socio-economically very well stable and who can afford their treatments. So should the government be paying the premiums for those families who can afford the treatment, who can pay for their services? So this is a big question that as currently the government has provided free of cost universal health insurance to whole of the population in the respective, like in KP. So should it be paying the premiums for whole of the population or only for the poor and the destitute? So this is one question. The other is that okay, fine, if you want to collect the premiums according to socio-economic status of the population, how would you ascertain socio-economic status in a country like Pakistan, where the economy is undocumented? 70% of the people are part of the informal sector. And if you want to collect premiums, how would we collect it? How would you collect premiums from someone who's informally employed in a semi-rural or semi-urban settings? So these are some of the questions, but obviously health insurances and its coverage to the general population and whole population does take a lot of time. Germany took almost 80 years. So I think there are questions, issues with regards to this, and I would like to, and I'll stop here, and I would like the esteemed colleagues like Dr. Sameen, who has been an authority on this, to have his comments on the points that I raised, and other colleagues as well, Dr. Arshad and Dr. Razia and other colleagues. So I'll stop here and I'll leave it open for the forum. Thank you.
Thank you, Dr. Khalid, for your insights, comprehensive insights. And I will come back to you again. And Dr. Sameen, may I ask you another question? Dr. Khalid has highlighted about the financial aspect of the universal health coverage implementation. And so this can be taken as a barrier for the implementation. What can be the other barrier? What are the other barriers for the implementation of the universal health coverage?
Thank you, Dr. Razia. So in my first my intervention, I was focusing more on what I call the normative aspects of universal coverage. Now I would like to focus, and I'm happy that both Dr. Arshad and Khalid has actually touched on many of those. So let's look at where are those challenges for Pakistan. And I think it's important that we highlight those and then try and find solutions to those. And Khalid has touched on those very well, actually. The first, I think we must remember, and I'm being optimistic, 30% of the people in Pakistan are below poverty line. If that's the number we use, just a round figure, we're talking of 70 million people. We're talking of a size bigger than UK. So when I hear the government saying we are going to cover everyone, actually it worries me. Because, with the current situation, limited fiscal space, to make that statement, and I worry whether this is a political statement or this is really something that we can actually do. So I would very much say that we should focus on the people below poverty line. Now, this is very much universally documented, and there is evidence, and this phenomenon is called progressive universalism. What it means is that when you're moving towards universal coverage, the poor should benefit as much as anybody else is benefiting. My worry is that when we announce that we will cover everyone, as if we have all the money to cover everyone, my fear is that the poor will again get deprived, and people who are more, more closer to the realms of power will perhaps get this benefit much more. So that's clearly something we should focus on, the 70 million poor people of Pakistan and provide them. And if we can do it, I think it'll be a big achievement. Now, the second point that I want to make is that there is something that I want to draw a distinction based on my discussion with at least 2 ministers of health of Pakistan. One is entitlement and the other is eligibility. And if you talk to many policymakers, they say, well, everybody's eligible, so that's fine, and so people can come and receive. But I think the reality is that what an insurance program does is it brings in a sense of entitlement to the poor people. So when they have an insurance card, they just don't, when they walk into a facility, they feel much more entitled. And that is, I think, the big difference that an insurance program, when it is well implemented, can make to the poor people. The third question is, from where will the money come? And let's look at what other countries are doing. I mean, it's not just Pakistan, it's certainly not the first country. So I want to clarify, Pakistan is not the first country. We are far behind and we are trying to catch up, as a matter of fact. Countries that have made much progress is Thailand, Turkey, and Mexico. The real country where I'd like to compare ourselves with, which is really making good progress nowadays, is Indonesia. Today, over the last 15 to 12 years, Indonesia has expanded its coverage to almost 70% of the population. And that's the kind of model that I think we need to be following. So where do the premiums come from? Given that, as Khalid said very rightly, that we have a huge informal sector, people are poor, or even if they're not poor, they're not paying taxes, how do we get them in? So the policy in Thailand has been that the government has taken care for people in the informal sector. The same has been the case in countries like Morocco, Tunisia, and now in Egypt. So we have to make that decision that we will be covering people who are in the informal sector once we have those resources. But our first priority, and let me again say, should be tackling and covering the poor people that I think need to be covered and they deserve coverage. The third point maybe I want to make is, who will provide care? I mean, we have in many parts of the country no facilities. And so many facilities will just crop up. And what we need to develop very quickly, and I would not like this to be done only by an insurance organization, but it should be led by the federal and provincial governments, is some sort of an accreditation program for health facilities in Pakistan. We don't have an accreditation program. So when we want to get into a contractual arrangement with the public or the private facility, that facility should meet some basic minimum standards. Now, the insurance agencies call it empanelment of health facilities. I would like to see more than just empanelment and basic minimum standards. These should meet certain criteria of providing quality services. So along with all this, we need to start a program of accreditation of health facilities in our country very, very quickly, so that then people can be, I could feel more confident that when people go to these facilities, they are receiving these kinds of services. The fourth point, and I'll make 2 more points and I'll close, is, this whole business of health insurance is not as simple. And I'm sure Dr. Arshad knows, and the world is documented that there is a challenge of billing and reimbursement, and that leads to corruption in the system. And we must bring in checks and balances in the system to minimize it. I want to give you one statistics from the US. In US, and it's not that US is the most corrupt system, it is because they have such a good documentation it is documented almost a good quarter of the reimbursement systems in the US private insurance is actually either wasted or it is lost due to abuse or due to fraud. And I think we must put those checks and balances in our system right from the word go. And that's an extremely important part of the governance of an insurance program. If you don't, I can tell you, I already am hearing information from many provinces, KP and Punjab, that at the delivery level, there is a fair amount of, those kinds of things happening, which we need to take care of. And finally, and I have recommended this both to the federal, but certainly we have been requested by the provincial government in KP, we need an independent third-party evaluation of the health insurance programs in our countries. As was said very rightly, now we are 6-7 years into this, I have not seen a formal, proper, independent evaluation of what is working well. And it's not to downplay, but it's to help improve the services that they're being provided. And I'm very keen that agencies and the government should come together and institutions like ours to be able to undertake that. And we hopefully next year, we will be doing this with an agency in KP province. And I would very much like something similar happens in other provinces as well. To finish, I very much like to recommend that this is an excellent initiative. We should continue with this initiative. But unfortunately, Pakistan does not have a good track record of implementation. We are not great implementers. I have worked in Iran for a couple of years as a WHO representative. I can tell you in Iran, the big plus of Iran is that they are great implementers. They're not great planners. They're not very good at strategic planning, but they're much better at implementation. Our challenge is we are not good at implementation. And I think we must improve our implementation capacity, whether it is decentralization, whether it is insurance or any other reform. If we can implement it well, it will make a huge difference to the people of Pakistan, to the poor people of Pakistan, and as I said earlier, who deserve so much better that we are offering them. So I'm going to stop here, although I can say again a lot, but I think we should be fair about how we are going to distribute this panel. So back to you, Dr.
Thank you, Dr. Sameen. Now next question is from the audience, from the Q&A. That is Mr. Nadimul Haq. This is question from you, Mr. Mohammed Arshad. It is who will pay the premium? We will pay the premium and expect the fantastic care seems fantastic. Who will take the loss? So this is one comment, and the second is, has anybody done the sums, or are we as usual changing? So, okay, so what will be the cost of this social health insurance, universal health insurance, in a simple way?
Thank you, Dr. Razia, and I'm so glad that Dr. Khalid, Dr. Sameen, and other जो क्वेश्चन जिन लोगों ने रेज किए हैं, they are very interesting and very relevant, I must say. Pakistan में health insurance, honestly speaking, is a very new phenomena, very new animal to this jungle. Still a learning curve is on, learning curve इसमें चल रही है, और we honestly believe कि इसमें जो है हम लोग जो हैं at a policy level or the implementation level कोई वो नहीं है, क्या कहते हैं उसे, अक्ल कुल नहीं है. Where we are always open to hear from anything from any quarter which could add any significant value for the improvement or the effective implementation or the effective service delivery to the target audience. Having said that, मैं एक अक्सर गुजारिश करता हूँ कि बहुत सारे जो हमारे हेल्थ के जो इंटेलेक्चुअल्स दोस्त हैं, एक्सपर्ट्स हैं हमारे, वो कई दफ़ा इस इनपेशेंट सर्विसेज बेस्ड सेहत कार्ड के प्रोग्राम को डाउन प्ले करने की कोशिश करते हैं कि ये बहुत ही लिमिटेड सर्विसेज को ये कैटर कर रहा है, और जो असल में जो बाकी जो सर्विसेज हैं वो ज़्यादा अजीम हैं प्राइमरी को लेके या प्रिवेंटिव को लेके. आई एम प्रीटी श्योर कि दे आर इक्वली इम्पोर्टेंट, बल्कि मैं इस बात पे ज़्यादा बिलीव करता हूँ कि वी शुड स्पेंड more and more on the preventive side and primary side. But in saving the lives, investing and delivering on the inpatient front is equally important, if not more. دوسری بات یہ جو ہمارے دوستوں کا ایک ہمارے کولیگ کا خیال تھا کہ اس میں جو ہے ایکریڈیشن سسٹم جو ہے وہ بہت اچھا ہونا چاہیے، ڈیفینیٹلی بہت اچھا ہونا چاہیے. ہاسپٹل امپینلمنٹ کا پہلے بھی ہمارے پاس 166 ڈفرینٹ آسپیکٹس پہ ایک کرائٹیریا تھا، اور لاسٹ ایئر ہم اس کو امپروو کر کے 1000 جو انٹرنیشنل اسٹینڈرڈس کے مطابق جو ڈیلیکیٹ آسپیکٹس ہیں سروس ڈیلیوری کے، انفراسٹرکچر کے، ایکریڈیشن کے، ان کو ہم نے انکلوڈ کیا ہے. ویری کمپریہنسو امپیڈلمنٹ کرائٹیریا جس پہ کہ انشورنس کمپنی اور یا پروگرام آرگنائزیشن یا متعلقہ صوبائی حکومت مل کے اس کی امپیڈلمنٹ میں اسسمنٹ کرتے ہیں. اور اس سے بھی پیچھے ایک قدم ہوتا ہے کہ جی متعلقہ ہیلتھ کیئر کمیشن جب تک لائسنس نہ دے تو وہ ہماری اسسمنٹ کے لیے بھی ایلیجیبل نہیں ہوتا. تو پہلے مرحلے پہ متعلقہ صوبائی حکومت جیسے پنجاب ہیلتھ کیئر کمیشن ہے وہ ایکریڈیشن لائسنس دیتا ہے، اس کے بعد ہم ایک کمپریہنسو اسسمنٹ کرتے ہیں، اس کے بعد اس کی اگر وہ ایلیجیبلٹی کرائٹیریا میٹ کر لے پھر اس کی ہم کوالٹی کیٹیگرائزیشن کرتے ہیں تاکہ اسی حساب سے اس کو ریمبرسمنٹ کی جائیں، اور اس کے بعد اس کے کنٹینیوس مانیٹرنگ میکینزم رکھا ہوا ہم نے. ان لائک مطلب ملٹیپل جو ہے دنیا بھر کے اندر جو بڑے پروگرامس ہیں ہیلتھ انشورنس کو لے کے، ہم نے یہ کیا ہے we make sure کہ ہر ہسپتال کے اندر ایک سروس کاؤنٹر موجود ہو پروگرام کا یا انشورنس کمپنی کا، جو کہ آئیڈینٹیفیکیشن آف دا بینیفیشری لے کے اور سروس کی جو ہے وہ ریکوائرمنٹ تک یا اس کی انپیشن سروسز کی فلٹریشن تک وہ یہ سارا کام کرتے ہیں along with the hospital staff. بھی ہم نے کوشش کی ہے. اس کے علاوہ ڈی ایم اوز ودن 24 آورس کو مانیٹر بھی کرتے ہیں، دین پی ایم اوز، دین پروگرام مانیٹرنگ، دین منسٹری مانیٹرنگ، دین ہیلتھ ڈپارٹمنٹ مانیٹرنگ ہم کر رہے ہیں. لیکن ہمیں لگتا یہ ہے کہ جب آنے والے دنوں میں اب اس کا یونیورسل ہیلتھ انشورنس کوریج ہونے جا رہی ہے تو اس کا اسکوپ یا اس کا جو دائرہ کار بہت زیادہ پھیل جائے گا. آئی ایم پریٹی شیور کہ یہ چیلنج اور بڑھ جائے گا. جیسا کہ ڈاکٹر صاحب نے ٹھیک کہا کہ دنیا بھر میں ہیلتھ انشورنس کے اندر جو ہے فراڈ اینڈ ابیوز کا ایک سرٹن ایلیمنٹ جو ہے انکلوڈنگ چاہے وہ یو ایس ہو، چاہے وہ یو کے ہو، چاہے وہ کینیڈا ہو، ہر جگہ موجود ہیں، اور وہ ایک بڑا چیلنج ہوگا. اس میں کوئی شک کی بات نہیں ہے. ہم اس میں کوشش کر رہے ہیں کہ اچھے طریقے سے اس کو کیٹر کرنے کی کوشش کریں، اینڈ ووڈ لو ٹو get the feedback and the guidance from experts like Dr. Sameen, Dr. Khalid and the rest of our colleagues working in this domain. اس میں ہم زیادہ سے زیادہ میں آپ کی ہیلپ بھی چاہیے ہوگی تاکہ اس کو ہم اچھے طریقے سے اس کی کر سکیں، مانیٹرنگ بھی کر سکیں. مانیٹرنگ ہر دو لحاظ سے کہ یہ اے سروس ڈیلیوری ہو رہی ہے، بی کوالٹی اس جو منیمم کوالٹی اسٹینڈرڈس ہیں کیا وہ مینٹین ہو رہے ہیں. بس اتنا چیزیں for last 75 years we are not able to develop in Pakistan. ہم نے ایس ٹی پیز جو ہے اب تک ہم نہیں کوئی ڈیولپ کر سکے ہیں. تو پہلی بار ہم کوشش کر رہے ہیں ود دی ہیلتھ ڈومین ایکسپرٹس، پبلک ہیلتھ ایکسپرٹس کو ساتھ لے کے کہ ہم ایس ٹی پیز بنا لیں تاکہ کم از کم ایک سسٹم، ایک کرائٹیریا ہو جس کے نیچے کوئی سروسز جو ہے چاہے وہ سرجیکل ہوں یا میڈیکل ہوں وہ ایکسٹینڈ کی جا رہی ہوں ٹارگیٹ بینیفیشریز کو، اور اسی کے آگے ہم اس کو یارڈ اسٹک کو ہم میچ کر رہے ہوں، میجر کرنے کی کوشش کر رہے ہوں کہ جی یہ اس کو ٹھیک چیزیں مل کے نہیں مل رہی. اینڈ ون جو ہر جگہ ہمارے دوستوں نے بھی ہائی لائٹ کیا اور ہمارے جو آف اسکرین جن لوگوں نے سوالات پوسٹ کیے ہیں انہوں نے بھی ہائی لائٹ کیا کہ جی اس کی فائنینشیل وائبلٹی. یس، فائنینشیل وائبلٹی جو ہے وہ ہر جگہ ہر فورم پہ کیبنٹ سے لے کے انٹرنیشنل جہاں بھی ہم شو کیس کرتے ہیں پروگرام کو، ہر جگہ یہ سوال ہم سے پوچھا جاتا ہے. کچھ نمبرز تو ظاہر ہے کہ میں نے آپ سے بھی شیئر کیے تھے کہ کتنی ہم اسپینڈنگ کر رہے ہیں، کتنی اسپینڈنگ اس میں ہونے کے امکانات ہیں. ہم نے کوئی 1 سال یا 6 مہینے یا 3 سال کی بات نہیں کر رہے، ہم نے اگلے 10 سال کے اس کے کیش فلوز جو ہے پروجیکٹ کیے ہیں. اور ہم یہ بھی اچھے طریقے سے جانتے ہیں بائی ورچو آف آور ایکسپیرینس ان دس ڈومین، کسی اور سے شاید بہتر جانتے ہوں گے ہیلتھ انشورنس میں ہم، کہ اس میں ہمیشہ جو ہیلتھ انشورنس کے کلیمز یا ہیلتھ کے کلیمز ہوتے ہیں وہ ہمیشہ پروگریسو کرو کو ڈیولپ کرتے ہیں. اس میں سے جو کاسٹ ایسکیلیشن ہوں گی اسے کس طرح سے مینیج کرنا ہے اس کی بھی ہم نے اپنے کیش فلو پروجیکشن کی ہے. اور ابھی چونکہ وہ بڑی اچھی بات کی ہمارے دوست ڈاکٹر خالد نے کہ جہاں شاید جرمنی 80 سال کے بعد یا 120 سال کے بعد ایفرٹ کے بعد ایز ویری ویل ٹرمڈ بائی ڈاکٹر سمین کہ پروگریسو یونیورسل ہیلتھ انشورنس یا یونیورسل ہیلتھ کوریج جو ہے کے تحت جو ہے قوموں نے سفر کیا ہے. ہم نے کوئی زیادہ ہی فاسٹ ٹریک کے اوپر 6 سال کے اندر یہ سفر طے کرنے کی کوشش کی ہے یا کر رہے ہیں. اس میں کوئی دوسری بات نہیں ہے کہ ہم ایسا ہی کر رہے ہیں. اور جو بھی ہماری ڈائنامکس ہیں انفارچونیٹلی دنیا میں 2 قسم کی نیشنز ہیں. دے آر 2 ٹائپس آف نیشنز. ایک وہ جو بہت ہی سویلائز طریقے سے بہت ہی क्या कहते हैं उसको प्रोफेशनल तरीके से अगले 20, 30, 40 साल का मंसूबा बनाती हैं, उसके बाद उसको प्रोटोटाइप करती हैं, उसके बाद उसको फेज वाइज लेके जाती हैं, और उसके बाद उसको आहिस्ता आहिस्ता कदम बढ़ाते 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 अगले 5 साल, 10 साल, 15 साल में उसको मेन प्रोजेक्ट पे लेके जाती हैं, ताकि उसको अच्छे तरीके से कोई उसका बैकलैश ना आए। बट वी आर नॉट अनफॉर्चुनेटली, जो हमारा पिछला 75 साल का रिकॉर्ड है, शायद हम उस किस्म की नहीं है नेशन, और हम किसी चीज को शुरू करते हैं और उसको अच्छी तरीके से नहीं चला पाते, कि हम बहुत अच्छे इम्प्लीमेंटर नहीं है, हमारे एक दोस्त ने कहा। लेकिन अब ये प्रोग्राम कम से कम 2 हुकूमतें क्रॉस करके आ चुका है, पिछली हुकूमत भी और उसके बाद ये दूसरी हुकूमत है। आई एम श्योर कि तीसरी हुकूमत में भी इसी तरीके से काम करेगा। इट शोज कि ये ग्रास रूट पे जो है वो डिलीवर कर रहा है। यही वजह है कि तमाम जो पॉलिटिकल लीडर्स हों, चाहे पिछली हुकूमत के हों या इस हुकूमत के, वो भी ये क्लेम करते हैं कि जी इसी प्रोग्राम की वजह से उन्हें जो भी पॉलिटिकल गुडविल मिली है या कामयाबी मिली है, वो इसकी वजह से मिली है। तो फाइनेंशियल वायबिलिटी का कोई इतना सच हमें इशू नज़र नहीं आता, और हम इसको अगले 10 साल 15 साल में चीज़ों को देख रहे हैं। प्रोग्राम को प्रोग्राम मोड से निकाल के इंस्टीट्यूशनलाइज करने जा रहे हैं। नेशनल हेल्थ इंश्योरेंस एंड फाइनेंस कमीशन का एक इदारा इस्टेब्लिश करने की कोशिश कर रहे हैं। अगले 2-1 महीने में एक्ट ऑफ पार्लियामेंट लेकर आ रहे हैं, ताकि इसको अच्छे तरीके से हम इस्टेब्लिश कर सकें, और कोई नई आने वाली हुकूमत बहुत आसानी से किसी विम या विश के ऊपर इसको उखाड़ पिछाड़ ना कर सके। अब आज के इसका जो फाइनेंशियल कंट्रीब्यूशन मैकेनिज्म है, उस पर भी हम उस पर काम कर रहे हैं। अभी शायद हम पहले मरहले पे जो अगले 2022 से 25 तक जो है मरहला फेज 3 है हमारे प्रोग्राम का, उसमें तो हम ये कोशिश कर रहे हैं कि किसी तरीके से इसको अच्छी तरह से रोल डाउन कर लें। बट 2023 एंड बियॉन्ड हम इसमें कंट्रीब्यूशन मैकेनिज्म जरूर लेकर आ रहे हैं। ये कंट्रीब्यूशन मैकेनिज्म को हम लाने के लिए और कर रहे हैं कि जहाँ अफोर्डेबल सेगमेंट्स जो हैं वो कंट्रीब्यूट करें अपनी फैमिली के प्रीमियम को, या उनके जो एम्प्लॉयर हैं वो कॉस्ट बेयर करें, ताकि थोड़ा सा उस साइड से भी सपोर्ट हो जाए कंट्रीब्यूशन पे। और फ्यूचर में ये भी तजावीज़ हैं कि खासतौर पर जो अफोर्डेबल सेगमेंट्स है वो को पेमेंट्स या डिडक्टेबल्स जो है उस किस्म की चीज़ों को भी लाइक एनी अदर इंटरनेशनल मॉडल उसको भी इंट्रोड्यूस किया जाए। अभी हमने पिछले कुछ 2-1 साल पहले तजर्बा किया था डॉक्टर जफर मिर्जा के ज़माने में, कि जी हमने फिजी ड्रिंक्स के ऊपर और सिगरेट के ऊपर एक छोटा सा हेल्थ लेवी लगाई थी टू सपोर्ट दी इनिशिएटिव लाइक सेहत सहूलत प्रोग्राम। तो उसमें भी कोई मेरा ख्याल है कि पहले साल में कोई 30-32 अरब जनरेट हो गए थे। तो अभी मेरा ख्याल है थोड़ा स्टैंड स्टिल किया हुआ उस लेवी को दोबारा से, उस किस्म के जो टैक्स वाला मॉडल है उसे भी पार्शियली अडॉप्ट किया जा सकता है। एम्प्लॉयर कंट्रीब्यूशन और इंडिविजुअल कंट्रीब्यूशन, ये तमाम मॉडल्स हमारे टेबल पे मौजूद हैं, और हम इन्हें प्रायोरिटाइज कर रहे हैं कि किस तरीके से आने वाली टाइमलाइन में इसको हम एग्जीक्यूट करेंगे। और जो मैंने आपको एक रफ सी एक फिगर बताई थी कोई 200 अरब की, आप इसमें देखिए कि इसके भी प्रैक्टिकली कोई 3 हिस्से होंगे फॉर ऑल प्रैक्टिकल पर्पस। पहला हिस्सा जो होगा कोई 60-70 अरब का, वो अल्टीमेटली कंट्रीब्यूशन मैकेनिज्म पे जाएगा, चाहे वो एम्प्लॉयर दे या एम्प्लॉई दे या अफोर्डेबल सेगमेंट खुद भरें। बी, जो पब्लिक सेक्टर हॉस्पिटल पैनल पे आ रहे हैं या काम कर रहे हैं, तो उनके पास जो हेल्थ इंश्योरेंस क्लेम की सूरत में जो पैसा वापस जाएगा गवर्नमेंट की किटी में, तो वो भी 50-60 अरब या इससे कुछ ज़्यादा होगा। और जो बाकी 50-60 अरब या 70 अरब बचेगा, नेचुरली वो बिलो पॉवर्टी, जैसे डॉक्टर साहब कह रहे थे, तो बिलो पॉवर्टी का जो प्राइस होगा, टिकट प्राइस होगा, नेचुरली वो गवर्नमेंट की जिम्मेदारी है। बिलो पॉवर्टी के लिए हमेशा गवर्नमेंट को उसमें आगे इनिशिएटिव लेना होता है, तो उसको हम करेंगे। अब कंसीडरिंग ऑल दीज नंबर्स, आप 60-70 अरब की गरीबों की टिकट साइज की बात ना करें, आप 200 अरब की भी बात कर लें, जहाँ कोई 5-1 हज़ार अरब 5200 अरब रुपए आपका FBR का रेवेन्यू हो, 7,000 अरब रुपए का एनुअल बजट हो, तो विद दिस नंबर्स 650 अरब का आपका जो है सिर्फ हेल्थ बजट हो, तो विद दिस नंबर्स अगर हम 150-200 अरब उसको नेट कर लें तो शायद 100 अरब भी बनेगा कंट्रीब्यूशन मैकेनिज्म। और उसके बाद जो है हमारा जो हेल्थ क्लेम की सूरत में पब्लिक सेक्टर में वापस आएगा, तो उसके बाद दिस इज वेरी मच वर्केबल कॉस्ट। लेकिन आई थिंक कि ये चीज़ प्रोग्राम भी बाकी तमाम चीज़ों की तरह इवॉल्व करेगा। हमें नहीं पता कि आने वाले सालों के अंदर इकॉनमी किस तरह से बिहेव करेगी, किस तरीके से हम चीज़ों को आके लेके चलेंगे, जिस तरीके से सिचुएशन का तकाजा होगा या ज़रूरत होगी, इंशाल्लाह उसी तरीके से हम इसकी सर्विस डिलीवरी को भी कोशिश करेंगे कि इंश्योर करें। अभी भी हुकूमत के पास टेबल पर है कि हम एक हेल्थ केयर सेक्टर में इन्वेस्टमेंट स्कीम लेकर आएँ और पूरे पाकिस्तान की हॉस्पिटल मैपिंग करके जहाँ जहाँ हॉस्पिटल दस्तयाब नहीं हैं वहाँ हेल्थ केयर इन्वेस्टर्स को दावत दी जाए कि जी बिजनेस केस मौजूद है और आप यहाँ आके सर्विस डिलीवरी की फैसिलिटीज़ बनाएं. तो ऑल दिस थिंग्स आर ऑन वेरी मच टेबल एंड वी आर वर्किंग ऑन ऑल दिस डायमेंशंस. So I'm very thankful for all the guidance and the feedback from my colleagues, and we look forward for more third-party validation. जो है इसकी अगले जनवरी से हमने ऑलरेडी अवार्ड कर दी है एक इदारे को और वो करने जा रहे हैं. नेचुरली वो भी जब आएगी तो इंशाल्लाह हम तमाम स्टेक होल्डर्स के साथ और हमारे इन कॉलीग्स के साथ जरूर शेयर करेंगे. एंड वी वेलकम एनी काइंड ऑफ फीडबैक. बहुत शुक्रिया.
Thank you, Dr. Arshad, for very well explained and very positive and hopeful scenario of the social health insurance. And I'm sure that with your this commitment, we will get some, we will go through this and we will get the objectives of this program. And in the last, Dr. Khalid, let me ask you, as the health is a devolved subject and the implementation is at the provincial level. So is there any mechanism developed for the implementation and monitoring of the universal health coverage packages at the provincial level? Thank you.
Universal health coverage and its benefit packages, all the provinces have developed their provincial universal health coverage benefit packages according to their needs, and they will be having intra-provincial governance mechanism to update or revise the packages with time as and when the evidence evolves. Federal government will play a role of coordination between the provinces and global sort of reporting on the UHC and its related indicators. For that purpose, a governance mechanism which involves all the provinces and the areas has been put in place, and the apex forum of it is the Interministerial Health and Population Council. So there is a governance system in place already at the federal level, and the provinces are in process of developing one for themselves as well. Yeah.
Okay, thank you, Dr. Khalid. Anyone from the audience participants, if they want to ask some question, please raise your hand and you can ask. They cannot. Okay, Dr. Abid, I think this was a very, very important and very fruitful discussion, and we could hear the two very large interventions which are promoting the health of the people of Pakistan, like the social health insurance and the universal health coverage. And Dr. Khalid very well explained the difference between the universal health coverage and universal health insurance system. And Mr. Arshad really explained very well the interaction and the of these two systems. And Dr. Sameen has highlighted about the quality and the good examples from the other other countries where this universal health coverage or the health coverage is better, and they have implemented the interventions which we are going to implement in future, and also about the health insurance systems in the other countries, and which can be where, and these examples are these where we can benefit from them because of the their context is I think somehow is the same, and in some countries, but not in we are not talking about very advanced countries. So thank you very much for your insights, and thank you very much for accepting this and for joining this discussion. And I think we will come up with something which will be very which will improve these two interventions for improving the health of the people. Thank you, Dr. Arshad. Thank you, Dr. Khalid. And Dr. Sameen was busy in some other meeting, so he has left. Thank you very much. Thank you all participants for participating, for asking questions. And thank you very much. Thank you all. And thank you, team of the SDPI, for organizing for arrangements. And and thank you, Dr. Abid Suleri, if he's, I think he's not. So thank you very much.